patient was referred to me with a dislocated capsular bag. As you can see here, it's shifted inferiorly, and you can see in this region here that there is no zonules. It's completely absent. Now, interestingly, this patient has no history of trauma and presented to the referring doctor's office with a pressure of 43. Now, in terms of the management of this case, there are many different options. The first option is to salvage the capsular bag. And so how would we do that? How would we approach this case? Well, starting the capsulorhexis, you want the capsulorhexis centered, not here at the light reflex, but on basically here. So you want to center your capsulorhexis kind of right here. You don't want to center it here, obviously, where the corneal light reflex is. You want to center it here. So your capsulorhexis has to be shifted intentionally. Now, once you have a capsulorhexis, you want to be able to bring the capsular bag back to the center. And so how can we do that? Well, we can do one of two things. Number one is we can use capsular retractors. And capsular retractors through your incision will go here and basically shift up the bag superiorly, and then you can go ahead with phacoemulsification. You could also use iris hooks, but they're more likely to tear through the anterior capsule. So I would recommend capsular retractors, or probably an option that's very, very stable is if you place a capsular tension segment early on. And we all know what a capsular tension segment looks like. Once you've created the capsulorhexis, slide the capsular tension segment in this region here. Here is where the central eyelet is. And what you do is you place an iris hook through the eyelet as such, and then you pull up. And this will give you a broad capsular support. When you have capsular hooks, you have it's not so much a broad support as much as it is a focal support. But if you have a capsular tension segment, you'll be more likely to bring this lens back superiorly. And once the capsular bag is centered, you can then go ahead with phacoemulsification. Now, this particular cataract is not too dense, so it should come out relatively easily once the capsular bag is well centered. And at the end of the case, if you want to salvage the bag, which is in this particular case not a bad idea, then what you do is you use the capsular tension segment and then you fixate it to the sclera using Gore-Tex suture. That's my preference. Alternatively, you can do a 2-point fixation. So Gore-Tex basically involves looping Gore-Tex through the central eyelet and then through the sclera. You're going to basically create a scleral loop, and the knot, as I will illustrate in dotted form, will be buried. So this would be the knot. And so that's one approach. The other approach is the double flange technique. And so what that does, and I've shown this technique in a separate video, is you take 6-O-proline. So again, this is the capsular tension segment. You take 6-O-proline, you feed it through the eyelet, and then you flange. So if I have proline here, you use cautery to create a flange here, and the flange will become like a stopper right there. And again, I have a very clear video to show you how to do this technique. And then you tent up, you pull up. Once you have the appropriate tension, you will flange this side as well. And so this is called the double flange technique or the Canabrava technique. I do prefer Gore-Tex because sometimes these capsular bags can contract late, months or years later, and the flange itself can weaken and actually uh, extrude through the sclera, and you'll have a dislocated bag again. If the capsular bag contracts in a Gore-Tex loop, there's no way for the Gore-Tex loop to break apart. So that's basically one option is salvaging the capsular bag, going ahead with phacoemulsification, and using the following instruments: iris hooks, capsular retractors, and a capsular tension segment. Of course, one thing that I didn't mention, which goes without saying, is to place a capsular tension ring at some point, but that's not the critical instrument, it's more the instruments I've already mentioned to you. Now, option B is not salvaging the capsular bag. Option B is removing the entire capsular bag. And you can remove the entire bag as one piece, as in a lensectomy, and then going ahead with your preferred method of secondary IOL fixation. So alternatively, what I can do is remove the entire capsular bag, lens material, and then go ahead with intrascleral haptic fixation. And we've talked about this technique on many occasions, but basically we're marking 2.5 millimeters from the limbus, 2 millimeters across, placing a three-piece IOL and anchoring the three-piece IOL with cautery to create flanges that stay into the intrascleral tunnel and will act as the method of IOL fixation. I hope you found this video to be useful, and thanks for watching.